This is the picture of Nepal Police Hospital, which is located in central Kathmandu. So I think most of you have already visited this hospital. So for the past 2 years, we have been running our IR OPD and varicose clinic in our hospital. So today my presentation will be based on how I am managing the cases of chronic venous disease. It's like my experience. It's a reflection of my experience on managing those cases. So chronic venous disease is very much common due to the nature of our job as a police officer. The prevalence of chronic venous disease is even more higher in our setup. So it's a spectrum of signs and symptoms, which is mainly results due to venous hypertension. Either maybe defect in SFJ or SPJ or incompetent perforator mainly, or in other conditions like post-thrombotic syndromes or May-Thurner syndromes. So I'm taking these snapshots from European guidelines of management of chronic venous disease. So it's a CAP classifications. So I have jumped all those things, anatomy. I hope all of you are very much familiar with venous system, anatomy of venous system of lower limbs. So according to the CAP classification, which stands for C for clinical, etiological, anatomical, and pathological. So according to the clinical classifications, it ranges from C1 to C6. So which will I will elaborately discuss in coming slides. So these are etiological classification, whether the disease is due to primary causes in vein or secondary causes, like in case of May-Thurner syndromes. In anatomical classification, we will look for whether it's in superficial vein incompetence or it's perforator incompetence or deep vein incompetence. Similarly, pathophysiological classification, it tells us about the either the chronic venous disease is due to reflux or obstruction. So coming to diagnosis, so basically we diagnose in clinically, we look at the symptoms and signs in the lower limbs, but the main thing we detect anatomical defects by ultrasonography. It stays as a mainstream. So in some cases, CT or MR venogram needed. So this is a picture of a woman. So we can see a varicosity in a typical location. I have done a Doppler, but her SFJ, SPJ, and perforators are competent. SFJ and SPJ are competent, but over here, there was an incompetent perforator which leads to this varicosity. In this kind of situation, only the ablation of perforator, or you can do sclerotherapy, will be the game changer. So this is another case with a history of IV drug abuse. He comes with a palpable lump of varicosities in proximal thigh, so, and a venous leg ulcer. So I did ultrasound. So here we can see just proximal to the SFJ. SFJ was incompetent. There was reflux from the SFJ. Just proximal to the SFJ, I could not visualize the common femoral vein and iliac vein due to this acoustic shadowing. So this is his image. We can see the collateral vessels. We can see the collateral. And I sent this case for CT venogram. So in CT venogram, I found that there is a very good cross-pelvic collaterals. So I took this case for GSB ablation. So after that, I have sent this case to TUTH for venoplasty because the main defect lies in common femoral vein. So this is the management protocols. So what we have medical management, we have some venoactive drugs and stockings. Class 2 stockings for most of the varicose veins. For post-thrombotic syndromes, we give class 3 stockings. Class 2 and class 3 stockings differs in the pressure. Like class 2 stockings is like 20 to 30 mm of Hg pressure, where in class 3 it's 30 to 40 mm of Hg. The another thing is endovenous thermal ablation. We have laser ablation, we have RFA, we have microwave ablation. So with the introduction of this thermal ablation, the paradigm has shifted from the conventional surgical ligation and stripping of veins to the ablation procedures. And we have non-thermal ablation like glue embolization, which I am not doing, and sclerotherapy. So these are the common venoactive drugs. Out of this, I am using calcium dobesilide, which is very good for pain, heaviness, and fatigue, as well as for cramps, paresthesia, and pruritus. So coming to C1, so in case of C1 management, like assurance is quite good enough. C1 is like telangiectasia or reticular veins, spider veins in the limbs. Assurance is enough. Most of these cases has no any symptoms, despite they only worries about cosmetic purpose. So if they have cosmetic, you go for treatment. Otherwise, just assurance or class 2 stockings is quite good enough. And always do the color Doppler to look for the incompetent perforator, incompetent SFJ or SPJ. So this is a case of C1, and I choose to do sclerotherapy, and this is a Tessari method. We take 1 ml of sclerosing agent. Commonly used sclerosing agent is sodium tetradecyl, and mix with 4 ml of air, and just with the help of 3-way cannula make this foam. So here I'm injecting the sclerosing agent. So basically this treatment is only for cosmetic purpose, and we have to look for the SFJ or SPJ incompetence. If there is SFJ or SPJ incompetence, we have to manage that. So C2, this patient belongs to like they have large caliber varicosities, 3 to 4 mm, more than 3 to 4 mm. Most of these patients don't have symptoms, but some patient complains of pain, fatigueness, and heaviness during evening time. So I manage this patient with medical management. My first approach will be medical management. But if the patient has symptoms and they opt for treatment, I do like color Doppler. And if there is SFJ incompetence, I ablate GSB with laser, or SPJ, I ablate SSB as well. So this is my first case, who has incompetent SFJ, SPJ, and perforators. So these are the images of pre and post procedure within 1 week. I have done laser ablation of GSB, SSB, and incompetent perforator of bilateral lower limbs. So these are the hardware. This is the our laser machines, and these are fibers. So here under ultrasound guidance, I am cannulating the GSB. So this is the securing the sheath and inserting the our fiber, laser fiber. The tip of the fiber must be at least 3 centimeters away from the SFJ or SPJ. Then based on the caliber and thickness of GSB to the skin, we use watts, and we just ablate the vein. So C3 patients, they have complaint of edema in bilateral lower limbs. No necessary we can visualize their varicosity or not. Varicosity may not be visible. So in this condition, we have to rule out the other systemic causes of edema, then do Doppler study, and if there is incompetence, then go for ablation. Similarly, this is the C4 case. We can see the color changes, blackening. So we call it lipodermatosclerosis. So in this kind of also patient, we do ablation. So what I mean to say is up to C2, so we can do with medical management. After C3, it's like I'm managing with ablative procedure. And in C4, this patient has a incompetence of SFJ, SPJ, and perforator. I have ablated all, and this is the pre-procedure, and this is 4 months post-procedure. We can see all the blackening part of the skins has disappeared. So C5, so it's a healed venous ulcer. Here are, this picture shows the healed venous ulcers. Again, the treatment modality will be the ablation, thermal ablation. So C6, this patient comes with venous ulcer. The typical location is around the ankle joints. And this patient has lipodermatosclerosis as well. And this patient has a history of venous ulcer, non-healing venous ulcer for 3 or 4 months. So suddenly he came to my OPD, and I have examined. So he has also all the systems, all the anatomical points like SFJ, SPJ, and there are multiple incompetent perforators. So which I managed with thermal ablations, and these are the post-procedure images after 2 months. And in case of a venous ulcer, make sure that, and believe me, you can find incompetent perforator around the ulcer sites. So just if you manage to manage that incompetent perforator with sclerosing agent or thermal ablation, so the ulcer will be healed. It's like magic. So coming to post-thrombotic syndrome, it's little technical, challenging, and lengthy procedure to manage. So in case of post-thrombotic syndrome, what happens is the prevention is the key to manage. Ideally, this patient comes with a history of acute DVT in past. Our ATTRACT trial or CAVEN trial, they have proposed, they have advocated the management of acute DVT with catheter-directed thrombolysis is far better than conventional medical management. In case of medical management, what happens is we can prevent the recurrence or propagation of the thrombus, but the remnant thrombus inside the vein is always there. So I use Villalta scoring for grading and severity of the post-thrombotic syndrome, and management depends upon the scoring system and anatomical abnormalities. So this is the Villalta system. So here are the group of signs and symptoms from pain, heaviness, cramp to redness and ulcers. So if the scores lies in between 0 to 4, there is no post-thrombotic syndromes. If the score lies between 5 to 9, mild post-thrombotic syndrome, and 10 to 14, moderate, and more than 15 or ulcer, severe PTS. So here again the Doppler study, or in some cases CT angiography or MR venography are needed to know the extent of the thrombosis. So sometimes it becomes dilemma. There is a thrombosis, still there is partial thrombosis and incompetent SFJ. What to do? Should I ablate the SFJ or not? So it's always that kind of question comes in my mind when I am managing post-thrombotic syndrome. Sometimes I go with the medical management, like 4-layer dressings, giving them aspirins and venoactive drugs. Sometimes I took the case, but the main thing is we have to manage the thrombosis inside the deep veins, either by venoplasty or by stenting. So these are the ATTRACT trials and CAVEN trials. So I have published an article around 6 months back. Based on that articles, I have total patients were 64. The most common complications that occur is paresthesia. The more distally you puncture the GSB, the outcome will be much good. But the chances of having paresthesia is much more. No matter how much good you give perivenular tumescents, there will be paresthesia. It's around 36% of my cases I have observed paresthesia. So after this study, I have chosen another method just to puncture the GSB below knee, just below knee. If there is varicosity, still after the procedure, just give sclerotherapy. So this is one of the complications during the procedure. My tip of the fiber that got stuck inside the vein within the thrombosis, which later I removed with surgical management. So this is the AHIT 1. I have ablated the GSB at least 3 centimeter distal to SFJ, but the thrombus is propagated up to the SFJ junction. And this is another case in SPJ. The thrombus is reaching up to the SFJ, and some part of the thrombus you can see inside the lumen. And another thing is this is the burns. These are also common. I am showing few cases. So I have borrowed this image from Dr. Manish. Thanks for this image. So it's a large varicosity over the limb. This is after the 1 week post-procedure image. So we can see the pre-procedure and post-procedure image, and some bruises also. And this is after 2 months follow-up. So in conclusion, this is chronic venous disease is much more common, and this must be fall under the domain of IR, because why I am advocating this is we like diagnose the case, we see the anatomical defects, and right at the moment we are thinking about the management, where we should ablate, either I have to go for sclerosing agent, or I have to just go for medical management. So, and yes, in post-procedure follow-up also we do Doppler. Doppler is key. So IR can manage this CVD effectively. Thank you.